Medical boards test your knowledge.
Bedside test your judgment.
On Boots and Boards, we bridge the gap between the bedside and the boards.
I'm Kristen.
I'm Dr. Cochran.
Let's get started.
Let's rock and roll today.
Do it. I'm excited.
You should be excited. This is your specialty right here.
I don't know about that, but it is my favorite.
We're going to talk about respiratory case today.
Yes.
And then we're really going to get in a little bit of the nitty gritty between pneumonia and bronchiolitis.
Yeah.
Both super high yield topics. I know I use super high yield all the time, but I really mean that in this time. But you are going to see a lot of this at the bedside, both in the adult world and in the pediatric population. So let's make sure you got all the tools to be successful.
Yeah, let's start with a case.
I love a good case.
We have plenty to choose from.
We do have a lot to choose from, and ones we have been involved in together. And this one was kind of a scary one.
It was scary. So we came in and we had a 15-day-old female admitted with RSV. She was only day 2 of illness, which is important. Usually peak of bronchiolitis is day 4 to 6.
Absolutely.
And so little ones, especially at 15 days old, to already on oxygen at day 2 is concerning.
Absolutely.
So she was starting off at half a liter nasal cannula. And as the morning progressed, I think we had her up to 1 to 2 liters before I called you the first time.
So came on my morning shift, getting, breakdown on the day, who I'm rounding on. And I get a call from Kristen concerned that we are starting to escalate in this patient. 2 big factors she already mentioned that I'm already looking at with their bronchiolytic. The age, so being less than 2 months old already puts them at higher risk factors, and then what day we're on. So RSV, day 4 to 6, we're at day 2. We know we're going to get worse before we get better. We need to have our ears and eyes perked.
Yeah. Another concerning thing was she had an apnea monitor on, which is that's protocol at that age for sure. And she had some alarms overnight. We weren't sure if they were true alarms or if the lead had fallen off. But as the morning progressed, we were starting to see that we were having true apneas.
True apnea is pauses in breathing that's greater than 20 seconds. So babies, they're weird. They like to act weird, and they'll do things like rapid breathing or what we call periodic breathing. But true apnea is greater than 20-second pause, and she's starting to show us true apneic events.
Yeah. So the first thing we did was a blood gas.
We love getting a good blood gas. We mentioned a little bit in our shock video last week that a blood gas can give us a lot of information, specifically in a respiratory patient. So the first thing we're going to look at is the pH. Remember, pH normal is 7.35 to 7.45. We get her gas back, her pH is 7.3. So a little low, showing us a little acidosis, but not where we're overly concerned at that point. Second lab we're looking at is the CO2. So when it comes to respiratory acidosis, that CO2 is going to be elevated. Normal is about 35 to 45. Hers was 48. So a little elevated, but nothing that we were overly concerned at this point or needed to change.
However, as the morning go on, the apneas continued to get worse. She was getting more hypoxic, so we did go ahead and initiate high flow.
So high flow nasal cannula is a step up from our traditional nasal cannula. What's the max that you can do for nasal cannula?
I believe 4 to 6 liters.
4 to 6 liters. But we've got to step up from just traditional nasal cannula called high flow nasal cannula. So it's a little bit different than our traditional nasal cannula. Traditional nasal cannula is going to give us, when we're looking at delivering oxygen, comes right out of the wall, and it's going to give us that when babies are having hypoxemia, really any patient having hypoxemia, we can slap on a nasal cannula to help raise their SATs. But high flow helps not only with the oxygenation part of it, but the ventilation. So that CO2, that not able to get the CO2 out of the lungs, that rising level we are seeing in the blood gas, high flow initiation can help bring that number down. The other thing that can do is stimulate babies who are having apnea. Right. So it's helping them to remember to breathe.
Yeah, that's good. Couple questions for you,
going
back a little bit.
Yep.
So what clinical factors most strongly predict an admission in a bronchiolitic baby?
Great question. So there's 3 factors I look at. Number 1 is, do they need oxygen? So are they persistently hypoxemic? So do they need supplemental oxygen on the floor? Normal SATs are greater than 88%. Typically we like greater than 92, but greater than 88% is normal. So if they're persistently below that and need some supplemental oxygen, they need to be in the hospital. Second one is dehydration. These babies really struggle with their feeding. They're breathing so darn hard that it's hard for them to be able to breathe and eat. So they often will get very dehydrated. So do they need IV fluids or NG for either Pedialyte or some type of supplemental formula? And then the third thing I look at is parents' comfort level.
Yeah.
And that's a hard one, but sometimes these parents are really struggling to be able to maintain the health of their baby at home. And so if they're uncomfortable, that makes us uncomfortable, oftentimes need to come to the hospital.
Next question. How do you differentiate between bronchiolitis and pneumonia?
Ooh, that's a fantastic question. Oh, there you go. All right, so let's look at this. So bronchiolitis and pneumonia. Bronchiolitis is a specific diagnosis for kids less than 2. It is when you have inflammation of the small airways. Babies already have small airways, and now we're causing inflammation even more into those small airways. That's leading to edema, that's leading to lots of mucus. So these babies will have these really tiny airways, and we're plugging them up due to a virus. Now, bronchiolitis can be triggered by any virus. What's the most common reason we see bronchiolitis on the floor?
RSV.
RSV. So that's the number one virus that you're going to see cause bronchiolitis in less than 1 year of age. Very important that you're able to identify RSV. We do a nasal swab to test for it these days, so it's really important that you identify RSV on the boards. It's a paramyxovirus. So one of those viruses you've got to be able to identify not only RSV, but what class of virus it's in. Not real life application,
No.
but you've got to answer that on the boards for some reason. So identifying RSV and identifying how these patients are presenting. What do you typically see with the baby coming in with RSV? What are the signs and symptoms?
We have increased secretions, lots of boogers, lots of snot.
Yeah.
So keeping that airway cleaned out is really important.
Absolutely.
Tachypnea.
Tachypnea, and we already mentioned the one we most worry about.
Apnea.
They can have low-grade fevers, but we don't see a lot of fevers. Not something that you have to have. You can absolutely have RSV with and without fevers. Now, let's compare that to pneumonia. You need to know a lot about pneumonia on the boards. How pneumonia differs from RSV or how pneumonia differs from bronchiolitis is bronchiolitis, again, is inflammation of the small airways. Pneumonia can be bacterial or viral, and it's when you have typically a consolidation or you have an infection of the alveoli, all right? So remember, bronchiolitis, you have inflammation of the small airways. Pneumonia is an infection of the alveoli. They need to know a lot about pneumonia. So we're going to talk about it.
Let's do it.
So there's a lot of different organisms that really come up on the boards. The 3 most common types of pneumonia, strep pneumoniae, Moraxella, and let me check my notes, make sure I know the one, Haemophilus influenza. Not only do those 3 commonly cause pneumonia, but they're going to cause acute otitis media. They can cause sinusitis. So anything that kind of comes to upper respiratory infection can also lead to a pneumonia. A couple tidbits to look at the big one, which is strep pneumoniae. So strep pneumoniae will often cause rust-colored sputum. That's disgusting. Yeah. I don't think I've ever seen rust-colored sputum. Have we seen? We've seen a lot of strep pneumoniae, but it's something that the boards love. So you need to make sure that you're looking for, if they say rust-colored sputum, you're in strep pneumoniae. The other one is a little bit different. So what makes bacteria and how they invade into the lungs and what they need to look at, they have these virulence factors. The one for strep pneumoniae is polysaccharide capsule. Do you know how I remember that?
How?
It's really great. Mnemonic, not even mnemonic, great way to think of it. So polysaccharide is multiple sugars, okay? So strep pneumoniae is multiple sugars that get down into the lungs and causes a consolidation or a lobar consolidation pneumonia. When you eat ice cream, do you like to eat ice cream by yourself? Never. You want to eat that with multiple people. Polysaccharide, polyglucose, consolidated deep into the lungs.
That's pretty good.
Strep
Look at
pneumonia.
you.
You like that?
I like that.
That's how I remember that one. The other couple ones that the boards likes to talk about, and you will see clinically, is mycoplasma. So mycoplasma is teenagers. Mycoplasma pneumoniae is an atypical. Now, instead of the typical, which is going to give you that focal consolidation or that lobular pneumonia, these are more widespread throughout the lungs. We had an outbreak a few years ago of some really bad mycoplasma, where a lot of patients were coming in the hospital needing supplemental oxygen in teenagers, which is not a common thing that we typically see. Yeah. So we have to make sure you think about mycoplasma pneumonia and, ages 5 and up, and really in that teenage. How you remember their valence factor is mycoplasma has no cell wall. So think of it like this. What you typically see on X-ray is widespread or patchy infiltrates. No cell wall, no boundary, goes throughout the whole lung.
Interesting. You're so smart.
Not even close. But it's a good way to remember, because the boards is not going to tell you, can you identify mycoplasma? It's going to ask you, can you identify factors that are making it present in the lungs? The big one for mycoplasma is no cell wall. Other one you need to know about is Legionella. Never seen Legionella.
I was like, never heard that one.
That's right. Causes three big things. It's a triad: hyponatremia, diarrhea, and pneumonia. So those ones, and typically in older populations and from contaminated water source. The boards likes to ask it like this. There's a big conference going on and everybody breaks out with diarrhea. Their labs show a super low sodium and they all have pneumonia, which can be very deadly. So big outbreaks from contaminated water source, usually fountains.
No, thank you.
No, thank you is exactly right. So those are some good ones. The other one I want you to make sure you know about is Klebsiella. Never seen Klebsiella pneumonia, but we do see aspiration pneumonia. Klebsiella is commonly associated with aspiration. So that's contents that came up from the stomach sometimes, or things that shouldn't get down into the lungs, aspiration. And that Klebsiella is a common one that you'll see. Other ones, alcoholics, because when they go and pass out, they're at a higher risk for aspirating. So Klebsiella. Current jelly sputum. Rust-colored sputum, current jelly sputum.
There you go.
Got to memorize all the things
I'm
that
hungry.
are associated with that, right? Can't wait for lunch in that way. So remember some of those tidbits or those high-yield facts that you may see come up on the board style questions and be able to identify from that way. Big complications that you can see with bacterial pneumonia. Again, you can get viral pneumonia. It's not as common. These are the ones the boards really like, and what we're seeing in clinical practice is bacterial pneumonia. Mm-hmm. Treat those with
antibiotics. Gotta love them.
Gotta love them. Big complications that we're trying to prevent with antibiotics is obviously progression of their lung disease, is if they get like an empyema or an abscess that can form. The other one is ARDS, or acute respiratory distress syndrome. That is where we're looking at going to the ICU and being on a ventilator for long periods of time. So that's what we're trying to prevent them from getting to, is with the initiation of antibiotics. Now, big tidbit that they like to test you on the boards. When it comes to pneumonia, it's something called a VQ mismatch. So that's a ventilation perfusion mismatch. It's actually a low VQ mismatch. With pneumonia, you're having disease, remember, at the alveoli. And that causes you to have a low ventilation versus a perfusion. So you have a low VQ mismatch. And these often present with hypoxemia, is when you have VQ and a low. So bad lungs equals bad ventilation. That's when you're getting a low VQ mismatch.
There you go.
Did you learn?
Oh, so much.
So much?
Love that.
Crazy. No one's ever going to ask you on bedside if you know if it's a high or low VQ mismatch.
But we need to know both.
But we need to know both.
Because we're here for
We're here for the both things. We're bridging that gap, aren't we? Bridging that gap. But it is really important that you be able to identify that the hypoxemia in pneumonia is due to a VQ mismatch, and it's a low VQ mismatch.
All right, so getting back to more of a bridging that with bedside questions that also could potentially be on the boards. How do you approach a child who isn't improving after 48 hours of antibiotics?
After 48 hours antibiotics, number one, you want to make sure when you're treating a pneumonia that you are giving it that time for those antibiotics to really kick in. But if you're getting that within that 24 to 48 hours and they're either not getting better or they're starting to deteriorate, you need to look at, do we need to escalate our antibiotic management? And so do we need to go to broader spectrum antibiotics to think of these more atypical bacteria that you could be missing?
What bedside finding changes your management the fastest?
Well, that's a great question. I would say if they're more persistently hypoxemic. So if we're dealing with more of that VQ mismatch, I know that I'm causing more and more damage to the alveoli. And so that I'm going to need to really get in and look at, is my antibiotic working, or are we looking at one of those complications? Do they have a potential empyema or abscess starting to form? So persistent hypoxemia is something that's really going to look at that. And then overall has the patient looking. On our case last week when we talked about shock, it was a pneumonia patient going to shock. So we're starting to see some of those symptoms of more widespread disease.
That's good. Last one, if you could teach one thing to never miss, what would it be?
Don't be afraid to escalate the antibiotics. So if you have a sick patient, and you've given it that time, or they're starting to deteriorate, start thinking of these other bacteria that you're not covering with your current antibiotic management.
That's good.
Absolutely. I mean, we've seen that. How many pneumonia patients?
Many
Pneumonia patients. And these are ones that they're going to come on a physical exam. They're going to have those fine crackles or diminished air sounds. They have higher fevers as opposed to our bronchiolitic patients are more of those wheezy, low-grade fever because it's viral triggered with bronchiolitis. More times than not, especially in the hospital setting, we're going to see bacterial triggering our pneumonia.
That's good.
That's excellent.
So what happened to our 15-day-old baby?
That was a good case, and one that I think is a great opportunity to learn about. So again, we had a 15-day-old baby, so we have a young infant who's starting to have apnea, and now we're on high flow. We continue to have more apnea. Okay, I get a direct call from Kristen that this kid is starting to deteriorate. Big things we were starting to see was more apnea despite being on high flow.
Yeah.
And so we needed to do something a little bit different.
Yeah.
You calling me is scary.
I don't call often.
Don't call often, and I came running because we're starting to see more and more of these apnea events, even despite the interventions that we were having. We had to escalate pretty quickly with this baby, so ended up needing to go to the ICU. There they received caffeine. So that's a common thing that we'll do in babies less than 1 to 2 months of age. Their respiratory drives are still immature, and so actually giving them a boost of caffeine can help wake up that respiratory drive.
Yeah.
So they got a bolus of caffeine and then unfortunately needed to be intubated, which is not an uncommon thing in this age group.
Especially that early in illness.
Being day 2, starting to be in day 3, it was only going to get worse before it gets better.
Yeah.
And again, that pathogenesis in bronchiolitis is all of that swelling and edema and mucus plugging in their already small airways. So you plug up that diameter, they very quickly can escalate to quit breathing.
Yes, but she did get better, and
after probably about a week or so, which wouldn't be uncommon, patient did remarkable, came back down, and we were able to discharge her home.
Yeah.
Scary case with a good ending, but you can see that these babies, especially RSV bronchiolitis, can escalate quickly. When it comes to the boards, it's being able to identify those different patient populations. We're dealing with pneumonia, which is more going to focus on the bacterial causes. Are we dealing with bronchiolitis, which is going to focus on our viral causes? How to determine those, and then ultimately, how do you treat them?
That was good.
I thought it was all right.
That was fun.
You liked it?
I love respiratory.
It's your go-to.
It is my go-to.
It is your go-to. Next, we want to talk to you guys about asthma. Now, we could keep going with asthma for hours upon hours. That's extremely board relevant and clinical. How many asthma patients we've seen? Daily. And so we want to make sure that you guys have all of the information going forward, but focusing on pneumonia and bronchiolitis today so you can slay the boards.
That's right.
Slay the bedside.
Slay the bedside. Please like and subscribe, Boots and Boards, and I hope you have a great day. Thanks.
See you next time.